Our first topic is novel therapies in AML and the changing role of transplantation. And our first speaker is Dr. BREDESON. Yes, BREDESON.
Thank you, Professor Rosette. My first talk was sort of a normal talk. We had data and things were good. This talk is less optimistic, as you can tell by the title. So novel therapies versus AML and impact on transplant. My money is on AML and transplant. So the short version of my talk is that novel therapies have not changed anything with regards to transplant for AML. I thought we'd talk a little bit about a couple agents where people have some data and then actually spend 10 or 15 minutes talking about why I don't think that targeted therapies in AML are going to be an answer for us. And then I was saying to Hari at break, I should have just talked about the potential of CAR T cells, but in AML so far there have not been a successful application there yet either, so maybe we'll learn something. And I'm going to talk a little bit about MRD, and a couple of things that came up in Hari's talk I'm going to maybe come back to. So this is just this basically tells us why picking out one target in AML and making a drug or a molecule against it or an antibody is unlikely to work. It's just to show AML, a bunch of patients up to the age of 65, all of the cytogenetic and related molecular abnormalities that can occur in these patients. And in patients with, say, an 821, 25% of them have a KIT mutation, 5% have an EZH2 mutation, et cetera, et cetera. So very heterogeneous illness is the short reason. And so we have not David versus Goliath, David being these little drugs but David versus Medusa. So if you cut off one head, you hit one target, you're going to have 7 more targets against you. So to think that something that targets just one area, CD33 or FLT3 or Vidasa, in whichever way that drug may work, can somehow overcome all of the heterogeneous nature of the complex molecular abnormalities in this disease, I think it's hard to see how that could be. But let's look and see what we know. So FLT3 inhibitors, I'm not going to go through a whole bunch of detail, everybody knows, but FLT3 mutation occurs in about a third of AML. It's the FLT3 ITD, internal tandem duplications, that are the problems with the increased risk of relapse. And if you have a fancy lab, they can tell you if you have a lot or you have a little of the mutation, so the mutation load seems to be important. And there's been first and second and third generation inhibitors. And the first generation inhibitors, and the only one we have regular access to where I'm from anyways, is sorafenib, but you see the other ones there, and they're not really specific. So, we're not talking about very narrow targets with the first generation. They also happen to hit JAK2, PDGFR, VEGF receptors, and KIT. And now that may be a good thing or it may be a bad thing. We don't really know. Maybe it's not so much necessarily just about FLT3, but about some other thing that they're targeting if they help. And I would say the short form of the summary is that they're not particularly helpful, except maybe getting some patients to transplant. Occasionally after transplant, you can use them to buy patients some time, but they're not curing anybody. And actually, there's a recent randomized trials published showing that they actually don't benefit population in the non-transplant setting. And then there was a small phase 2 study, or a phase 2 study in Middlestorn, which did show some benefit in the non-transplant setting of extending event-free survival in younger patients. The more recent version of these drugs, quizartinib, is a second generation, I guess you could call it. So it's going from having 4 or 5 targets to maybe being more selective to FLT3, but still having some KIT. The side effects relate both to that and potentially the benefits. So side effects are diarrhea and fluid retention primarily. And you can see that although I'm giving these drugs a hard time overall, they still in some patients can temporarily bias benefit by getting remissions in people who are otherwise refractory to chemotherapy. And as we'll learn in a little bit, the problem with these drugs, as I said, is you're only targeting one or two areas, and they end up having resistance either because a TDK mutation develops, or they may lose in a clone the TDK mutation, and therefore no more benefit. And that drug is in phase 3 trials. Then there's some other ones, more recent versions. You can barely even say their names, crenolanib and gilteritinib. And again, these are very similar. And what's interesting is that they work in patients with and without FLT3 mutations. So you have to wonder what the mechanism of action is of some of these medications. But they may have a role in getting patients with chemo-refractory disease to transplant, but the amount of experience so far is limited. So in the allotransplant setting, with FLT3 disease, allotransplant is still the therapy, of course. And sorafenib has been used in retrospective studies, and they say there's promising phase 1 data post-allotransplant, but the problem, and we'll come back to this again later, is that they can't get the drug started till at least 6 weeks after the transplant, and sometimes it's 4 months after the transplant when you're starting the drug. And if you transplant patients with FLT3 AML, you know that by 4 months after the transplant, a bunch of them have already relapsed. So I think this would be a recurring theme that we're going to touch on is if you're going to do something in the allo setting with the targeted therapy, you have to do it before the disease recurs. And so there are active phase 2 trials accruing. And then there's a last drug, gilteritinib, as another CTN trial right now. It's a phase 3 study randomized against placebo, post-transplant, 2 years of maintenance, FLT3 mutated AML, primary outcome being leukemia-free survival. And they've chosen this because of its more narrow, more precise targeting and tolerability. And then the interesting thing about this study will be, even if the study doesn't actually pan out in terms of benefit, the MRD, they're going to be doing MRD and validating between labs MRD, which is a big problem. Everybody's MRD is different. And they're going to try and demonstrate that MRD in AML is a valid biomarker in that it predicts outcomes. So that's it for FLT3. Hypomethylating agents, azacitidine being the example for now. So I would say that the enthusiasm is not in keeping with the data. So basically believers believe that this agent will have benefit, but the data is not there yet to have such enthusiasm. So there is some efficacy in MDS and AML. Everybody who's used it knows the MDS data, and there's some limited AML data in low blast count, and then some phase 2 data in higher blast count. And there's a new version, guancidabine, coming that may have some benefit in AML. Marcos de Lima has a lot of work in the post-transplant, either as prophylaxis or maintenance therapy, I should say, or post-transplant with relapse and DLI. And if you look at those papers, there's maybe 6 or 8 papers. They're all phase 2 or retrospective experience, and they all say the same thing that you would say of anything if you asked anybody. Responders, some people respond. You do better if you have limited amount of disease before you're treated. If you didn't relapse for a long time, you're more likely, and if you went into transplant with remission, you're more likely to benefit. So responders do better, and people with less risky disease do better, and that's the same with anything we do. And as this is all phase 2 data, it's hard to get too excited about it. In terms of prophylactic intervention or maintenance therapy after transplant, again, the idea is that you can buy time until immune reconstitution, or you can accentuate sensitivity to an immune response from the patient, from the donor's immune system. The early studies, though, I thought when I reviewed them before coming to the meeting, aren't particularly promising. The summary of those would be that you can't give enough of the drug, and you can't give it early enough, It's rather toxic early post-transplant, and there's over half of the patients dropped out because of toxicity. And despite that, there's a phase 3 trial testing to see whether this is a good intervention post-transplant. So we'll have to see. I'm not convinced, but at least they're doing the phase 3 trial. And preemptive based on MRD, very limited data, and the results have not been as you would have hoped. Particularly, it didn't seem to change the tempo of the MRD if it's when it started to rise. So this is just a slide to point out all kinds of targets, novel therapies targeting specific things in AML. FLT3 we talked about. The other ones that might be of interest we'll look at later is IDH1 or 2 inhibitors. CAR T cells I'm not going to talk about yet. The trouble there is finding the right target, and this might be more interesting related to the microenvironment, which you're going to touch on. So I want to take a few minutes to say about some lessons from cytogenetics and molecular biology that highlight the challenges of finding a magic bullet or a targeted therapy for AML. And we're going to look at three different concepts: molecular definition versus clinical definition of disease, tumor heterogeneity and evolution, and the idea of pre-leukemia. So this I think is quite fascinating and humbling as a clinician, because basically the net result of this study is that clinicians aren't very good at classifying AML compared to molecular biologists. And they did three things. We're going to talk about three things. They took 194 patients who had secondary AML defined as prior MDS. That was 93 patients. They had 101 patients who had a clearly documented history of therapy-related AML, meaning that they'd had prior chemotherapy or radiation for malignancy, and then 105 patients who had a beautiful clinical history for just walking in the door with de novo AML. And I'd highlight that it took 81 sites in 22 countries to come up with these patients, which highlights the challenge of doing work in AML. So they have those 194 plus another 105 patients to look at here. And the first thing they did is that we think about these clinical entities that we talk about, and we think that they're somehow different clinically. But the problem is it's not an exact science being a clinician, and you need to have good data, and you have to have prior clinical information to be able to do that objectively. And I don't know about you, but I often get patients referred from elsewhere with a diagnosis of AML, and you can't get anything else beforehand. You have no idea what their CBC was 3 months ago. They can't tell you, I had treatment for something, I think it was a lump. They don't know what they had. So it's hard to get a good history. But if you characterize them molecularly, we're going to find out something interesting. So I don't pretend to be a molecular geneticist, but I think we can all agree that this is the secondary AML patients who are all supposed to be the same clinically, and you can quite clearly see that there's a group here who have genes that a group in this up here, more common here compared to down here. There's these ones that are pan AML or de novo AML. They seem to be kind of across everybody. And then there's this group down here that then there's a P53 group, which I can't find it on here now. But you end up having a secondary AML group, a P53 mutated group, and a group that have these de novo things. And you can see the genes that are different. And we'll keep coming back to this idea that there's different types of genes that are mutated in the different types of clinical presentation. So secondary AML have this type, and there's a de novo group that have sort of common. There's a P53, and then these ones are down here. The de novo case is sort of later mutations, and we'll see where they are in the evolution of the cell. So one clinical group, three different molecular groups. And you said you could divide them into these three types, and that they all have distinct clinical features, even though we think that they're the same disease. And we'll come back to how this highlights our problem. The second thing they did is they took therapy-related AML And they found essentially the same thing, that there's a group of within the 105 that have this secondary, oh, I do the same thing as that man. The secondary type, there's a group that have sort of look like de novo AML, even though they have a clear history of having prior therapy. And then there's a group that have the P53 mutation, de novo AML with these characteristic later mutations that we'll talk about. So again, secondary AML breaks into three groups. TAML breaks into the same three groups with essentially the same genes. And they have a very distinct clinical presentation. And then they said, okay, well, what if we just took de novo AML and saw what happened to them? And they found the exact same thing again. So if they took the de novo AML patients, 105 clinically, and they looked at them, and they had, again, the three types of gene profiles. One, the secondary type, who had 4 times as many driver mutations, a median of 4 compared to 2 driving mutations. The genetic, cytogenetic abnormalities were more common in the P53 than the others, and clinically, the de novos were a bit younger than the other 2. So again, 105 patients, all of whom had the same sort of healthy, walked in with AML. They turn out to have genetically and clinically different diseases. And that turned into not just how they look, but how they respond. So people who have de novo AML were more likely to go into remission with 1 cycle of therapy compared to the other group, and they actually had an improved survival compared to the other genetically defined groups, even though they were all clinically presenting the same. So it gets worse than that. So with disease progression in those patients, 60% of them developed a new driver mutation, something that means that you're going to have a new target if you have targeted therapy. And most of those were sort of late lesions, and we'll see what that means on the next slide. And the secondary type mutations, sort of the early ones that are initiating events that you might see in what we think of as leukemic stem cell, they persist even though you're in remission. So you get rid of the RUNX1 type, the driving mutations, and you're left with the initiating mutations. And the targeted therapies are only targeting these late genes that we have. They don't target the early ones that are the initiating events for malignancy. So here we see this model from Welch talking about you have a stem cell, it might have something wrong with it. It gets an initiating event. These ones up here were the ones that we were seeing as the secondary AML, as the ones that were the bad drivers early on. And then later on they get another hit with these cooperating or driver mutations, and these are the ones that are late. And then other things happen, and you end up getting subclones that keep acquiring these different types of lesions. And then we said that you treat with FLT3, well, you get rid of this, but you still have this cell here. And this cell is just waiting for another hit again to develop leukemia. So we have targeted therapies that are targeting an epiphenomena almost, like a subpopulation of the whole group. You say, well, that's great, except I don't have a 59 gene panel at my institution, which I don't, but apparently other people do, like Hari and rich American centers. But cytogenetics is good too, so you can do fish and simple things. And actually, Hari showed it in one of his myeloma patients that they had subclones. And it probably the same in myeloma, it's probably the same in CLL. If you have a primary clone and you have a subclone by cytogenetics, you have a worse outcome. So when they looked in a bunch of AML patients by FISH, they found that out of 2,600 patients, 16% had a main clone and a subclone. But if you just looked at people who had a bad karyotype, a third of them had a secondary clone or a tertiary clone coming out of it. And that if you looked in the worst cytogenetic, the high-risk group, half of them had subclones. And that the development of subclones was an adverse prognostic marker, and they had a different survival curve that was significantly worse than patients who only had the one clone. So then the next thing is, okay, so it's what does clonal evolution mean? And what does it tell us as well? So we talk about the founding clone. I'm skipping some of the details, but a founding clone is the one, you know, that picked up the TET mutation and then maybe the FLT3, and then you have this acquiring additional mutations over time that eventually give you AML. And then you give them chemotherapy, and you can lose genetic subpopulations or you can gain them. So it's not like you just always get things, you can lose them too. And if you lose the one that you're targeting, then you have a clone you can no longer target. And as, again, Hari pointed this out with myeloma, that you have these different clones that come in waves. Well, the problem with AML, if it comes in a wave, it's a tsunami, right? It doesn't come like myeloma slowly as a wave. It comes as a you're dead wave. And then relapse can come from the predominant clone that you had a diagnosis, just like Hari said, or it come from a subclone, or it can have a whole new one, or it can come from a different pre-leukemic cell, one of those cells that has the initiation lesion only. And it shows you, just to show you the same essentially lineup of genes, these were ones that were gained at relapse, and these were ones that were lost at relapse. So you can see that 5 to 15% of patients are gaining lesions, but much more importantly, you're losing markers or losing genetic targets with relapse. So if you're treating FLT3 inhibitor, 85% of the mutations that they found were loss of FLT3. So how are you going to treat that with a targeted agent? And where do these cells come from? They come from being alive. So the older you get, the more likely you are to have these, which is a sad thing. So there's, I think, 4 papers, maybe it's 3 papers that all came out around the same time highlighting this. And when it came out, I was like, oh my God, I'm going to have to retire because I'm going to have pre-leukemia and I need to live before it turns over. So here's a New England Journal, Nature Medicine, another New England Journal paper, they were back to back, showing age-related clonal hematopoiesis and evolution. And again, so here they took, this is the one, I didn't go through all 3 of them for time, but here's the one from Sweden. The Swedes looked at 12,000 odd patients in a registry and did whole exome sequencing on them, something only the Swedish could do. They traded them for a Volvo or something. And what did they find? They found the same early initiating mutations that we talked about in the leukemia model. So there's a percentage of us, nobody in this room because we're all too young, but people over 65, there's as many as 10% of people are walking around with an acquired mutation in their hematopoietic stem cells and have clonal hematopoiesis because these mutations provide a growth advantage over normal stem cells. So then what happens is, does it matter? And it does matter because even if you don't die of leukemia, there's something bad about having clonal hematopoiesis. So this isn't 0, this is 100% and 95%. So if you don't have clonal hematopoiesis, you don't die in the next 10 years. But if you have clonal hematopoiesis, you have about, 4 times as much. So from 1% to 4% chance of dying just because you have this. Doesn't mean you get AML. It means something else is going wrong in your body as well. And this shows with time, percent of patients who acquire these abnormalities in their lifetime. So nobody has it, and then you start to get clonal hematopoiesis with these candidate drivers, but overall, as you get to be 80, 15% of us will have clonal hematopoiesis derived from 1 or 2 of our stem cells. So does that mean we have the same thing as MGUS in our blood? So you have MGUS for myeloma, you have monoclonal B-cell lymphocytosis that we worry about now in family members who are donating for a donor. And here, do you have the same thing in AML? You have MGUS, what's called CHIP in AML, so pre-leukemia that can then go on to these other diseases or AML as they acquire the second or third hit that comes along. Probably that's the case. And so again, as we age, we acquire these, jeepers creepers, I got fat fingers, I'm sorry. As we age, we acquire these, and then then something else happens, a solar flare, or we smoke a cigarette or whatever, and we get one of these, and then we have AML. So we're walking leukemic time bombs as we age. Okay, so it's not only important to know what's going on in your body and take care of yourself, you want to live in a good neighborhood. So it's important to know what about your neighborhood. So we're just thinking, here's a leukemic blast in the bone marrow, and we're talking about the bone marrow niche. And one of my colleagues, every time we talk about leukemia, is like, it's all about the niche, it's all about the niche. So if you take AML cells, they're actually hard to grow in the lab because they spontaneously apoptose if they're not maintained or nurtured by features of the hematopoietic marrow niche. And there's been studies done, really funky studies, where they can slice the marrow very, very thinly and identify that in people with MRD, there are leukemic primitive cells in these niches, and that's where relapse seems to come from. And that within the niche, the various factors support and protect the leukemia stem cell. They induce chemoresistance and they prevent apoptosis. And there's all different things here that do that, and we don't have time to go through it all. But it raises the question, in addition to targeting the hematopoietic stem cell, the seed that we talked about with chemotherapy, or could you have, there's some data about using targeted against CD123, a leukemic specific antigen, as opposed to an antigen that's also found on normal tissues. What about targeting the bone marrow microenvironment? Or what about doing both? And on this slide, there's a bunch of things that people are doing to think about that could target, interfere with the ability of the microenvironment of the niche to nurture and take care of leukemic stem cells by interfering with angiogenesis or migration or metabolism. And some of the drugs we know, so there's ibrutinib, sunitinib, bevacizumab that's used in lung cancer, and then plerixafor. And you could imagine if people had tried this before with GCSF years ago, they said if you give GCSF, the leukemic cells will come out into circulation and they'll be more sensitive to chemo. It didn't really quite work out as well as we wanted, but there is interest in doing the same thing with AMD 3100 or plerixafor, and people are trying that now to mobilize the cells from the niche so they're more sensitive to either targeted therapies or chemotherapy. And we have a trial going to open in our center very soon with dose-escalated radiation conditioning preceded by plerixafor to mobilize the leukemic cells into the circulation. We previously gave up to 20 gray conditioning and in graft. The marrow doesn't get fried, but you still have relapse. We think if we can move the blasts out from the nice neighborhood, that we could then have help there. So briefly about MRD. So we keep talking about MRD like it's the holy grail, but I remain, this is sort of a downer talk, I remain depressed about MRD as well. So the emperor may or may not have clothes. We don't really know yet whether MRD is all it's cracked up to be. I mean, there's a lot of things we know, well, minimal or measurable, because, you know, MRD used to be histologic remission, and then it was cytogenetic remission, then it was FISH remission, and now then it's flow, and then it's, you know, PCR. So we just keep changing the definition. So it's measurable disease. So you can imagine, you know, where are you measuring it? How much did you sample? How much disease is present? If you only have, you know, one leukemic cell in every 100 mils of your circulation and we take 10 cc's out, you're going to miss it 1 out of 10 times. How sensitive and specific is the test? And everybody's flow is different than the next guy's for MRD. And everybody's PCR is a little bit different than the next guy's. And now you're looking at the right population. So we just talked about, you start by identifying flow on a population of cells, and then that population may not be there later, but a subpopulation or a population that's lost some of the markers. So sometimes the clone you're following has disappeared, or the genetic marker you're following with an MRD test disappears, and yet you still have disease. And is it validated as a biomarker of clinical outcome of interest? Do we really know for sure that measuring MRD will tell us what's going to happen to the patient in total? And then there's some things that we all agree, right? It's always better to be negative than positive. Nobody's going to argue that not being able to find disease is a bad thing, but it doesn't necessarily mean that it's good, because as Hari showed as well, MRD negative people, some relapse. So just being MRD negative doesn't mean you're out of the woods. It just means we haven't got a sensitive enough test. On the other hand, MRD positive don't all relapse. So you can't say because you're MRD positive, we should intervene with a very toxic or potentially toxic therapy, because maybe a third of those patients will not relapse. And then you've gone and killed the person with TRM, and they were, and in the potential that they didn't actually have disease coming. And so mutation does not equal malignancy. We just talked about old people walking around with pre-leukemia. We know that people can walk around with 14-18 translocation, but they don't have follicular lymphoma. And normal people can walk around with BCR-ABL translocation and not have CML. So we can't equate a mutation with disease. And so you have to, not kill the patient trying to treat MRD when you don't even know for sure that it's going to resolve into an illness. And almost no data, this is the other thing, maybe in myelomas or some, but really there's very little data that intervening changes the outcome. So you say, oh, we have MRD, we're losing our graft, whatever, we got to intervene, we got to do something. Well, they still die. The leukemia still comes back, they still die. So until we have better ways of dealing with the problem, we shouldn't overreact. But it doesn't mean we shouldn't be studying it. We should be measuring it, and we should be figuring out what it means. But we shouldn't overinterpret and jump in on intervening. So, targeted therapy in AML is so far overly optimistic, and it has a limited role in AML. And I would say that an allotransplant for AML is the best targeted therapy we have right now. You're putting in an immune system, it's going to go find the AML and kill it. We just don't know what the target is that it's using to kill. Novel genetic and molecular investigations have highlighted how little we really can predict about AML in any one patient. The microenvironment is sort of the next frontier for trying to understand ways to interfere with the leukemic success and to get at the leukemic stem cell, not the ones that float around in our blood, but the ones that are hiding in the niches, many of them dormant, protected from the toxicity of chemo. And MRD is okay, but it can't do everything it's asked to be doing yet. It can't tell us which of our patients is 100% going to relapse or 100% not going to, and we should use caution when interpreting that data, particularly when what we're going to do is potentially toxic to the patient. And we really need well-designed trials, some of which Hari's talked about in myeloma, where we evaluate promising agents, but in a randomized trial setting. We do the MRD testing, and we randomize people to an intervention. We don't do a whole bunch of little phase 2 studies that say how great we are and then adopt those therapies because we can get access to them and never really know if we're doing the right thing. And that was BMT-CTN 1506, which is the FLT3 inhibitor study in AML, which is, I think, really a perfect study. Even if it's negative, it's going to look at MRD, as I said, between centers. It's going to look at the predictive ability of MRD, and it's actually going to test whether a FLT3 inhibitor, a recent version of a FLT3 inhibitor, can change the outcome. And it'll be interesting to see how soon people can get it in and how long they can stay on it. Because I'm going to talk again in another hour and a half. I'm going to show you, highlight again, the early problem post-transplant in poor risk disease is relapse before we can start adding these therapies. And with that, I'll answer any questions you have.
Thank you, Dr. BREDESON, for this presentation. Are there any questions or comments? Yes, please.
Thank you for your presentation. So you talked about the MRD, the impact of